the final session of what I think has been a fantastic conference. My name's David Oliver. I'm a consultant physician up the road, actually, at the Royal Berks in Geriatrics and General Medicine, but I'm also a trustee here at the Nuffield Trust. And this session is going to be on shifting attitudes and expectations over work. A couple of things to mention. For those who haven't seen yesterday, the publication of the staff survey for 2023, it's worth a read. Although it's quite depressing in terms of the amount of abuse and bullying and harassment people are facing. And I'm particularly concerned about the number of people who feel unable to raise safety concerns in their own organisation or outside and feel they're safe to do so. So I commend you to read that. It'd also be remiss of me not to mention that it's International Women's Day and the majority of the health and care workforce are female. I'm in fact the token man on this panel, as you can see, and the token hospital doctor. So on our panel, we've got Billy Palmer, Senior Fellow at the Nuffield Trust, who's led a lot of the work of the Nuffield Trust on workforce. And if you look him up on the site, there's a formidable output from him and his team about terms and conditions, workforce, reasons for leaving. I do want to draw your attention to an election briefing that's published today on NHS staffing, what health and care need from the next government, which was co-written by Billy and Lucina Olovic. It's full of interesting insights and some recommendations for policymakers. We also have on the panel Professor Smyth, who's the Chief Exec of Skills for Care. And I was very taken when we were planning this session with a report called The State of the Adult Social Care Sector and Workforce in England. And because of that report, was very keen. And also because we've got to stop having social care as an afterthought in these discussions. For a story I was writing for the BMJ, I did speak to the NHS England press team about why there wasn't very much about social care in the long-term workforce plan. And they said to me that we have engaged with colleagues from across the social care sector in the development of the plan so we can provide healthcare professionals to work in social care. But they also did say we are now supporting work by Skills for Care to develop a workforce plan for social care. So I'll be interested to know how that's progressing. Then we have Dr. Nishma Manek, who I've known for several years, very much an up-and-coming GP back a few years ago when I was working in the government. And she's now a GP at Granta Medical Practices in Cambridge, clinical fellow and the primary care director at the NHS England, and also the founder or the co-founder of a site called Next Generation GP, which is full of interesting resources, very much targeted at encouraging younger doctors, earlier career doctors into general practice and supporting them. And then Crystal Oldman, who's been the chief exec of the Queen's Nursing Institute since 2012, but also worked for a long time as a community nurse in West London and as an academic researcher and teacher. And we've got some themes for the session, really, about the changing nature of the health and care workforce, the fact that even within one cohort, people have different needs at different stages of their careers, the expectations from work change over time, but also generational differences in what people value. And you can see that playing out right now in the industrial relations dispute between the BMA junior doctors and the government, for instance. So we want to discuss a little bit the impact of generational differences on recruitment and retention and how we have to adapt workplace. And I'm a pragmatist. I think we've got to give people what they want to retain them in the workforce. There's no point judging or blaming. We have to adapt what we're doing if we want to keep people. We're going to talk a little bit about whether structures and design of career pathways in the health and social care are fit for this evolving landscape and generational shift, and a bit about the NHS long-term workforce plan and also the business about social care workforce planning. So what we're going to do in the session is Billy is going to do a short presentation around the current key challenges with that theme in mind about generational differences. And then we're going to come in turn to Oonagh and then Nish and then Crystal for about 5 minutes each. And then we'll go out to the audience and try and cluster 2 or 3 questions together at one time. And then we must finish on time. And if you haven't been tweeting or looking at the tweets, it's hashtag #NTSummit. The content from all the sessions will be available on YouTube fairly soon after the event. So I'm going to hand over to Billy.
I've actually got to go get my glasses. That's an aging effect rather than a generational effect, but. Okay, thank you. So, sort of obligatory provocative, semi-relevant quote to start off with. This from George Orwell. Each generation considers itself more intelligent than the one before, wiser than the one that comes after it. Let's hope we're a little less polemic than Orwell. Let's hope we are no less provocative in our thinking here. My role here is just to set out some of the key concepts to help describe this issue about changing expectations of the workforce. And hopefully in doing so, I'm also going to make the case that we need to take this a lot more seriously. Why should we take it seriously? Well, everyone else does. Industry is keeping a lot of management consultants in happy employment right now, getting them to write think pieces around what do we need to do to keep Gen Z happy, and before that, what do we need to do to keep millennials happy and participating in our workforce. And companies have done things. McDonald's had their own training and development strategy for millennials. And even Hollywood's got in on the act. I've got to say Jodie Foster, I think, is probably a better actor than she is a diplomat or a sociologist, but it makes the point that everyone else and all industries are talking about this. And there's a whole strand of pop sociology dedicated to changing expectations and behaviours of younger generations or subsequent generations. And when it comes to national bodies, you might recognise this person, Chloe Swarbrick, in her workplace, happened to be a parliament in New Zealand, where she told a fellow lawmaker, OK boomer, where she was interrupted whilst trying to make a contribution. But on a slightly more serious note, national bodies here have talked about this. Department for Work and Pensions have put out materials, even focusing on how they can get better engagement from their own workforce in terms of, and particularly focusing on millennials, about flexibility, social purpose, technology. How do we get people contributing better? I think what's quite interesting, whilst there's that example there of what might have happened in New Zealand, if you look at Hansard for mentions in our parliament of generations, it's almost silent. There was a handful of mentions of Gen Z in 2023. And I think that says something to a nervousness about trying to tackle this subject, because there's it's obviously challenging if you try to draw barriers between generations. But if US actors and New Zealand politicians are a bit far from home for us, what about in our health and social care sector? Well, there's been quite a lot of evidence produced on the generational effect on use of services. So once you control for age and changing access in healthcare, actually every subsequent generation since 1910, well, at least one paper has suggested this, every subsequent generation is actually using less emergency services. And also organisations have looked at the workforce implications here. So this is just on the bottom right-hand side, that's just a snapshot of the front page of a Health Education England deep dive, as it was called, looking at the research evidence on the impact of generational differences in the NHS workforce. People are conscious of this, and there has been some good research, but a lot of it, despite that, reads a little bit like horoscopes. And if anyone knows me, I absolutely hate horoscopes. For full disclosure, not everyone, and if you read managerial psychology books, not everyone agrees that there are such seismic differences between generations. And actually, people have pointed out, even talking about it can start to create these barriers which are problematic. So it's not a benign conversation in itself, so we need to be careful. I've already mentioned two generations here, Gen Z and millennials, so a slight recap. Bit of a primer here on generations. These are culturally specific. If you're in Bulgaria, you have a very different one. Two generations, effectively, pre-communist, post-communist. Japan, again, has a totally different set. But this is what you've probably been exposed to in the past. Often these generations are defined by year of birth and the age that relates to. And a concept that we'll return to here is the salient event. So what forms these generations or cohorts? When it comes to healthcare, we're not really talking about world wars, but if you keep that sort of idea that there are some formative events that are grouping people and giving them a certain sort of attributes and behaviours. And then for each of these, and this, if you're interested, is the proportion of the current NHS workforce. Apologies to Oonagh that quite a lot of my numbers are here at NHS specific. That's an artifact of the role that I do, but where the data is. So, millennials are currently the majority. It won't be long, though, until Gen Z are catching up with that. And then for each of these generations, you have certain characteristics that have been ascribed to them. Gen Z, flexibility, mental health support, demanding for that in their workplace, a demand to see diversity, equality, and inclusion. Take note those who want to hollow out EDI functions in hospitals, given that's a clear demand from that generation. But also in terms of personal ethics, there was a report from Deloitte where about 2 in 5 of these so-called Zoomers had rejected a job or an assignment based on personal ethics. They seem to behave differently. So some ground rules, many of which I've probably already broken, so apologies. Let's try to avoid criticising generations. There is no Menti quiz here on who is the most annoying generation. Let's avoid simple characterisation of generations. There is, of course, huge within-generation differences. And to describe that and also help you win pub quizzes, here are your living UK prime ministers by generation. And if you take baby boomers, for example, whilst these prime ministers, they may have shared a job, some of them shared a school, and some of them shared a university course, undoubtedly, well, it'll be difficult for you to argue they necessarily share the exact same motivations and behaviours in the workplace. And also, we're looking at generations here. We're not looking at the ageing effect. Some of those generations are thinking more about pensions right now. That's not necessarily because their generation is predisposed to think more about it. It's because the age they're at, it's a more pressing issue for them. So let's try to focus on those generations. Right, so you need to slightly forget what I've told you, you may already have, because we're going to try to redefine health and social care workforce generations. Because they're not every 15 years, as those social ones that I described are. They're probably a lot more common, and it's a lot more complex in terms of those salient events for our description here. And so here are some of those formative circumstances that might be changing the behaviours and motivations and experience of different cohorts coming through the workforce. It might be the nature of the student debt and their pay. In broad sense, in 1997 there were no tuition fees. Now it's £9,000 or so. And actually within healthcare you've got much more nuanced changes even within that, with the scrapping of the bursary, the introduction of maintenance grants. That's very likely to change behaviours. We know that that's a concern for some, and we know they're thinking about them when they're considering their careers. Cohorts are changing in terms of their demographics. If you look at just medical school acceptances, there's been a big change in age around the sort of 2000 period. There was a big shift there. If we look at gender, there's been a big shift from 1 to 2, female to male, to 2 to 1, female to male. And overseas, there's been peaks and troughs in this, but now we're at a very high point, about 1 in 2 joiners to the workforce, both for nurses as shown here, but also for doctors as well from overseas. It has in the past been much lower. That changes the nature of your workforce and probably changes their behaviours and motivations. Similarly, job opportunities. There have been times, nursing in the 90s for junior doctors in the 2000s, where they have struggled to get jobs. That will change how you then value employment and your behaviour within them. Again, contracts and pensions, they've changed. You can easily envisage how that might form cohorts who behave differently. COVID, I guess, both in terms of when people were in education, that changed their behaviours, whether they had to attend their educational setting, and we'll return to that very briefly, but even those working during COVID, and even the mandatory vaccine saga, you can envisage how that could change the relationship between the employee and their employer. And then industrial relations. I'm not so sure that this, whether to describe this as a formative circumstance or a bellwether of the fact that we have changing behaviours of different cohorts. It's certainly very different. So that's the theory of why we might have these cohorts. Are we seeing different things? So this is, apologies if it's a little bit small. So this is trying to set out what a career path would look like from your initial exploration of a career, that sort of self-assessment, career research, applying for jobs, applying for courses, through to retirement at the end. And here are some piecemeal facts. Some of them in that will appear in that general election briefing that we published today. So here's some good news, right? The current young people are really interested in clinical careers. 3 in 4 have considered a career in healthcare. The motivator, improving the lives of others. That's the key one when they're asked about that. I mean, the downside here is that 5 in 9 of those are put off by perceptions of low pay. But that perhaps speaks to the era rather than, given the industrial relations, rather than a generational effect. But that perception of pay might explain why we're seeing 1/3 fewer applicants in the latest data than 3 years before. But again, it might also be, this is not just a one-off, this could be a change in behaviours of those young people who are considering clinical careers. And then you've got attrition, for those who get on the course, attrition during training. And this is on medical schools. I mentioned earlier about the behaviours of those who trained during COVID. And the one clear predictor, so I'm told, of passing your medical school exams is attendance at your lectures. And attendance has gone down for that cohort. And they're seeing more of them struggle to pass their exams. Joining profession, we've seen this huge drop-off in nurses joining the NHS who actually were completing their studies. That has recovered slightly in the latest year of data, but it's still well below. Something different is happening. And if we look at the participation of GPs, for example, joining their profession, you used to be able to round it up to, on average, working 4 days a week. Now you can round it down to 3 days a week. This is a material difference. And in terms of satisfaction at work, we see different things. This is from the staff survey, a big change in people being, young people being enthusiastic about their job. It's difficult to unpick whether that is talking to the period, there is, the era that we're in, or whether this is something about a new generation. Certainly the academic literature, which has been published around generational changes in the workforce, suggests that there is something to be concerned about, and these generations do experience their work differently. And likewise, we see differences in postgraduates, doctors, more pausing. Some people seem to suggest that they will always return anyway. That's not true. You also get a doubling of those leaving the profession after their foundation year and before joining subsequent training. And then retiring, if you look at those GPs leaving and taking up pensions, they're twice as likely now to be taking early retirement. So hopefully that makes the point that we are observing something quite different. And can we do something about it? Well, one of the people plan documents had 156 actions for HR departments to do. They seem to think there's a lot you can do. If you could regenerate every HR and OD officer and re-employ them in the NHS, you probably couldn't do everything that is at our disposal. I mean, I could have copied on the right-hand side. There's some examples of things that could be done, national levels, local levels. You could copy this many times over and add new things. These are amenable. So why is it not happening? And this is my final slide. And I've added this because I wondered whether there's a theme here to the other conversations we've been having over the last few days. Do we have the language to talk about this in a sufficiently precise and nuanced way to then go away and act on it and make improvements? Right. One bit of audience participation. Put your hand up if you can see the different colour. Hands down. There's a tribe in North Namibia, and when they put, and this is actually the colours they used, and when they put this in front of them, they struggled to pick between that blue and that green, because they have the same word, buru, I think it's pronounced like that, that covers the same shade of blue and green, and so they don't differentiate. But here's the kicker, right? That's a different colour. And for them, it's a very clearly different colour because they have the language and they have the word to define that green compared to other ones. And the question is, do we have that language to define these generations? I won't pretend that I've tried to describe it and offer that today, but I think that's something we really need to think about. Do we have that way of assessing them and thinking through the solutions accurately enough? Thank you.
Thanks to Billy. So if you've got questions for Billy, we'll hold them till all three panellists have had their say. So we're going to start with Oonagh.
Yes. Just an apology from me to start. I'm coming up to the end of a cold, so my voice, I'm hoping will hold out, both because I'm a trooper, but also I really want to have this conversation. So I'll keep going. I suppose I just wanted to start with a bit of a story. So when I started in social care in Mencap, and I remember a young care worker aged about 20, and we were supporting a young woman called Michelle who she couldn't see, she couldn't hear, she couldn't speak. She only had the use of one arm, and this young support worker was doing an aromatherapy course, and she had this idea of spraying a different smell in the morning before supporting Michelle to get to bed, before she ate, a different smell before her mother came to visit her. And what we ended up finding was that actually where we thought that Michelle had the use of one arm, but it was quite involuntary, it could move, but involuntary, actually that wasn't the case. She started to be able to feed herself rather than be fed, and we ended up realising, I know she loves chocolate, she doesn't like peas, like the rest of the world. So we were able then to support her to eat the food that she liked. And I know that sounds like such a small thing, but if the only sense that you have is your taste and your smell, the impact of being able to eat food that you like every day, every meal, as opposed to not being able to. If you love your mother and you can look forward to her coming to see you that day because you know that she's coming that day because someone has sprayed an orange scent, the impact on quality of life is just absolutely unbelievable. You almost can't quantify it. We don't tell stories like that in social care. We don't tell it enough in terms of the careers that people can have and the impact that people can have on lives. What we hear is, come work in social care, you'll be low paid and undervalued. Well, no thank you very much, I'd rather not. Or come work in social care, you'll do something about bedpans, something about personal care, but I don't really know what that is. And you'll be an adjunct to the NHS. And actually, social care at its best is about prevention, it's about personalisation, it's about well-being, and it's about relationships. And what we hear from the newer generation coming through is that, well, what they want in work is they want flexibility and they want purpose. Now, there's some things we can't give you in social care. We can give you flexibility and we can give you purpose. We also need to make sure that the roles in social care are valued and valuable, and that's where we need to be focusing. But the flexibility and the purpose are two things that we can definitely do. We have a workforce in social care, so all of the data that Billy had was health. We have all of that data in social care. Have a look on the Skills for Care website. It's all there, we know it. We have about 8% of our workforce are under the age of 25. as compared to 12% of the population. So we don't have enough people. We also don't keep them. So 53% of our youngest population leave every year in their first year in social care. So 1 in 2 leaving every single year. We have a massive workforce, 1.6 million people, bigger than the NHS, makes up 5% of all jobs in England. So the opportunities in social care are broad and diverse. You've got every role that you can imagine in any business. We've got tiny organisations, we've got massive organisations, and everything in between. We also have a bulge of 18-year-olds coming through now that we're not going to see again this century. And so it is incredibly important that we get those people into social care, I would say, understanding the value of social care and being able to stay and progress. And we need them. So today we sit with a vacancy rate of about, the latest data, about 152,000 vacancies a day. But just based on demographic changes alone, if we don't make any other policy decisions and choices, which of course we will need an extra 440,000 posts in social care by 2035. So we don't have enough people today and we're going to need more tomorrow. But let's not make that a crisis narrative. Let's talk about that in terms of the opportunities for up to 440,000 people to work in excellent roles where you have purpose and you're valued. Although we shouldn't assume that we can't attract people in social care. We attract about 400,000 people into social care roles every year. It's a massive, massive amount. It's more than the population of Bristol. A lot of those people have come from social care and they'll be moving around within the system, and about 1/3 of those are brand new. They'll often come in from hospitality and retail, and when they leave, they'll often leave for health or other caring professions. And so that kind of brings me on to we need to attract more people, but we also need to keep them. And when we think about attraction, there is a real point to make around the narrative that we use, but also the channels that we use. So, I hate to tell anybody, but nobody under 30 uses Facebook anymore. So we need to be using TikTok. We need to be thinking differently about how we present social care. And then when we think about keeping people, social care has a turnover rate of about 30%. And so we've got a leaky bucket. We recruit people in and we're losing them at the other end. But we know what works. We've got 16% of our providers with less than 10% turnover. And that's been consistent. It used to be about 25% and that's reduced. And the 3 things that work to keep people are quality of role. So that's pay, that's terms and conditions. That's the balance of flexibility and stability. It's development. So the government reform programme about focusing on workforce development is exactly where we need to be focusing there. So the more you train people, the longer they stay. And the third thing is organisational culture and leadership. People often leave the organisational culture or their manager as opposed to the sector. And then just the final thing that I want to say, and I'm sure we'll pick some of this up in questions, but there is something about us presenting social care as part of the solution and not always the problem. So we have a lot to teach as well as a lot to learn. And I think that we need to be, as we're talking about our long-term social care workforce plan, we need to be thinking about the shape of care, the shape of work and the shape of education. And it's all of those 3 things, because what we have now is not going to be what we are going to need in the future. And I think we've got a real opportunity in a moment in time here.
Thank you.
And my voice held up.
Well done. Nish?
So I think the first thing I'll say as the token young person on the panel is that our generation are often billed as a sort of snowflake generation that can't really cope with the workload. We don't really care that much about being good doctors. But based on my experience of supporting newly qualified GPs across Cambridge for a number of years and running a leadership programme for young GPs across the country, I don't think that's true at all. I think our generation care deeply about being good doctors, and not just that, I think we also really care about trying to improve the wider system around us. But I do think that 2 things are true. The first is, I think, in general practice at least, the job has got harder, it's changed a lot. And the second thing that we don't often talk about is that we're going to be living for a lot longer. So I read an interesting statistic the other day that people who are currently 18 have a more than 30% chance of living to 100. And so I don't think it's going to be that unusual as the generations go on to see people working into their 70s and their 80s. And the reason I mention that is because the things that our generation want from work are not just sort of preferences. I think they're things that we really need to pay attention to if we want to stop generations from burning out. And we're losing people at the start of their careers that we cannot afford to lose. Thinking back to what Professor Whitty said yesterday about how much we're going to need generalists going forward, this is something we really need to pay attention to. And based on my experience, and it's backed up by surveys, I think 3 of the commonest factors that our generation want from work, similar to what you were saying, Oonagh, the first, I think, is a good team. So a team where you feel respected, supported, empowered to contribute, which really appeals to our generation's sense of entrepreneurism. We want to be able to change things around us and feel valued and able to do that. And I think particularly in general practice, if you've not worked in general practice, you probably don't appreciate how isolating it can be as a job compared to secondary care. So for me, I know what makes a really big difference between a good day and a bad day is my team. And I think as the job is going to get harder, the team is going to be even more important. The second thing I think our generation really want from work is flexibility. And particularly flexibility for things like caring responsibilities and childcare responsibilities in particular. So we're seeing an increase in the feminisation of the workforce. As Billy said, we are graduating with so much more student debt than previous generations, and childcare is expensive. We have the breakdown of nuclear family, so we don't often have the support of a family to help. So for those reasons, childcare and flexibility to enable childcare is really important. And also flexibility just to have a better work-life balance. And I don't think we should be begrudged for wanting a better work-life balance. There is evidence that our generation care about investing in relationships outside of work and other things. And going back to what I said, the job is harder and we're going to be working for longer. We should be supporting and encouraging our generation to have a work-life balance if we want to keep them in the profession for longer. And the third thing that I think that we want is development. So particularly, again, in general practice, we don't have protected time for development. It happens in our own time, really, compared to secondary care. So I think that sense of being invested in and that someone cares about your development is so important. And that's in 2 ways. It's kind of horizontal development, so even developing interests outside of the patient-facing work. And yes, that might take us out from seeing patients, but again, I think that makes for a more varied and sustainable career. And also horizontal development within the practice. I think lots of us are coming out of GP training not feeling confident to do the job of a GP these days, which, as we heard yesterday with AI and things, is changing so much. So ensuring that we're continuously developed even once we start working in general practice. So those would be my 3 things. So flexibility, a good team, and development.
Thank you. Crystal.
Thank you. So now I feel like the oldest person on the panel, and I definitely am. But I'm really pleased that I've got digital notes. So I've got paper. But I did have to ask Nish, was my battery going to go right down? And I am a baby boomer. And so, and it's really interesting listening to Oonagh and to Nish about, I would say, very, very similar things about nursing and about medicine. We have done quite a lot in nursing to increase the ways that people can come into nursing, and I think that's to be celebrated. I think there are many, many more ways. There was one way to come into nursing when I came in 40-odd years ago, but that's probably about the only positive thing that I'm about to say. We lost second career nurses. We lost those who were thinking about nursing when they'd already had a first degree in something else or had had children in their early 20s. And we lost them because, as Billy said, we pulled the rug by saying there is no longer a bursary now. So we lost particularly those who wanted to become mental health nurses and learning disability nurses. And that was the outcome of that was a lot of learning disability nurse programs actually closed because they were no longer financially viable. That is creating a huge problem which we need to do something about. And I know there are lots of people talk about the forgivable loans. Fantastic. We've heard about that yesterday as well. I think that should be explored, and I hope that the next government will intentionally explore that. But we do have to be careful because not all nurses work in the NHS. So if we say forgivable loans for those who work in the NHS, what does that say about the other 50% of nurses who work outside the NHS? What will happen to their forgivable loans? We know, as Billy said, about the fall in the UCAS applications. And my HEI colleagues tell me that this is because directly they see a relationship with the strikes. And they see it come into nursing, but actually you'll probably be on the street campaigning for better salary and better terms and conditions. Well, probably not. That's not the best way of attracting school leavers in and others to come into nursing. So salaries are important, but also terms and conditions. But if they see this being discussed on the TV, they're 17, they're 18, they're thinking about healthcare, perhaps they won't choose nursing. There are problems with retaining our students. So once we have got them in, we've got student nurses that leave, about 18% leave when they're in their first 2 years after finishing. When they qualify up to the first 2 years, we lose 18%, but we also lose 1 in 8 who are going through their training. Now, as the oldest person on the panel, I remember that was about the rate when I was training. I don't think Billy will probably know way more than I do, but I don't think that's changed greatly. I think we do lose nurses. I think people come in, they see what the job actually is and then think, probably not for me. So there is something about how we recruit and are realistic about what the job is. And we do need, I mentioned before about 50% of nurses not working in the NHS. We need to be much smarter about how we're articulating our workforce plans. Are we going to include, I'm glad that we are, I hope, going to be including the social care workforce, because a lot of nurses work in adult social care, they work in the independent sector, they work in the charity sector, they work in education, they work for the local authority, think of school nurses, health visitors, and so on. We must be planning for those too. And we need to calculate, as Nish said, that there's this, we've got about 90% of all nurses are female. They are predominantly going to be having the caring responsibilities. So we need to plan our workforce to build in time out during the next, what I've just heard will probably be about 50 years of work, which is kind of scary. And attracting them in, we know that what we have done is to try and rescue the workforce by recruiting internationally. And we know that 50% of all of those who came onto the NMC register last year were internationally educated nurses. That's 50%, that's not sustainable. And the majority came from 3 countries, from India, from the Philippines, and worryingly from Nigeria, which is a red list country. I talked about the flexibility. So that on the positive side, nurses have transferable skills that they can take across from the NHS into other sectors. My son's an anaesthetist, a senior reg anaesthetist, and he feels trapped by the NHS, which had never occurred to me before I had those conversations with him. He loves his job. He loves the NHS. But he feels trapped because the terms, the conditions, and there's nowhere else to go except, he tells me, Australia. And that's really worrying. But for nurses, we do have an option, and we don't see that exodus to other countries because we can work in a number of other sectors. The generation of school leavers definitely wants something different to what I wanted when I qualified as a nurse. Their expectation around flexibility, around the hours that they will be prepared to work. I have another son who his ambition is to earn enough money to work 4 days a week. So work-life balance is a priority for that generation. Flexibility in choosing, having the autonomy to choose when you work, is much more important. They're much more mindful of self-care and mental health than I ever was. And thinking about working till you're 70, well, when Professor Chris Whitty was speaking yesterday, I was looking at myself on that sort of right-hand side of the graph, thinking, well, that's pretty scary. But having a conversation with Deb Sturdy, Chief Nurse for Adult Social Care here, I was saying this morning, my generation, we didn't have any hobbies, we just worked. And I'm really scared now. I'm getting towards that right-hand side, retirement. I don't have anything else to do because I dedicated everything into the job, into nursing. And that's not healthy. I'm not saying that's right, but that's a massive difference to the generation that we're now seeing. So we do have to think about retention as well and how we retain our workforce, give them what they are looking for. The NMC have done some fantastic work looking at leavers and why they leave. And apart from retirement, looking at why they leave, the top 3 reasons are retirement, my physical and mental health, and burnout. So physical, mental health, and burnout, really, really important. We're just doing a piece of work at the Q&I around district nurses. It'll come out in April. And they are working, 43% of them are working 4 to 7 hours a week, unpaid overtime. That's the kind of pressures that we're putting the workforce under. How are we going to retain them? And how do those student nurses coming out and spending time in those district nursing services, they're going to look at that and think, I'm not prepared to do that. I want flexibility. I want to choose my hours. And I see the person that's mentoring me working an extra day a week for no money. So we do have to think about how we're going to give that, respond to what the nurses of this generation want. And just one last example, in that survey, 43% of the district nurses don't have a parking permit. So it's sometimes not about salary terms and conditions, it's actually showing how you value them to be able to go park outside the patient's home or close to the patient's home who you're about to give end-of-life care to, not to try and find the local car park, trolley everything to 5-10 minutes walk to the patient's home, and then realise you've left something and have to go back again, and then you just don't bother for the bureaucracy to go and claim your parking because actually it's not worth it, you don't have the time to do it anyway. So some of the things about retaining are just small things, but really meaningful as to how you value the workforce. Thank you.
Thanks to all the panellists for contributions and brevity. And before I go out, just, chairman's prerogative, I'm going to come back to each of you with a question. But I think one thing that's come through this is early career attrition, hasn't it? And actually in the election briefing, the rate of attrition in the first 5 years in nursing and allied health professionals is quite stark, and it's starting to happen for junior doctors as well in a way that wasn't the case earlier on. And it also struck me that, as has been mentioned, in campaigning for better terms and conditions, in highlighting the problems in the service, we could be putting potential applicants off. And I do worry about that. Although I supervise a lot of foundation doctors and talk to them about their career choices, and they don't seem to be put off by all the mood music so much as their current experience. But the question I had for you, Oonagh, was about, well, 2 things really. Number one is, what impact has points-based immigration policy had on recruitment? And the other thing is, how can you improve terms and conditions when so much of the funding for social care providers comes from local government, and when local government's been so financially hammered over the past 15 years?
So on the first question, when we think about how we get more people into social care, we really only have 4 choices. So we can keep recruiting the same people that we have always recruited, and they're fantastic, but there's not enough of them. We can radically change terms and conditions to recruit more people. We can attract different demographics. So men, younger people are the 2 biggest examples that we can recruit from abroad. In reality, we probably need to do a little bit of all of those. Last year, just in the year from March 22 to March 23, we saw 70,000 people coming in from being recruited internationally and working in social care, and they're absolutely fundamental to delivering our social care, and we need to make sure that we are good colleagues to those people, that we're welcoming them, that we are supporting them to settle in our communities, and we don't always do that, and so I think that's going to be incredibly important. But what we also saw last year was a reduction in domestic staff of about 30,000. And the year before that, we saw a reduction in new starters, about a 7% reduction in new people starting in social care. And so we have to do both, and we need to think about the broader picture in terms of how we are recruiting. And then your second question around terms and conditions and pay. And the pay is incredibly important, but we need to be clear what we're trying to achieve, because you would take slightly different approaches. So the biggest impact on whether you can recruit locally is your local labour market. And so you need to do what you can in social care to differentiate yourself from the local labour market. Pay is a part of that, it's not all of it. It can be the purpose in the role, it can be how we talk about the role, it can be progression. Retention then is a slightly different question. We have squeezed our pay differentials over the years in social care. So with the national living wage, we've seen base pay go up, which is fantastic, if differentials haven't gone up at the same rate. So in 2016, you would have seen about a 33 pence an hour difference between the most and the least qualified, or the most and least experienced care worker. Now that's about 6 pence an hour. So if I start social care today, I'll get about 6p an hour less than someone who's been in social care more than 5 years. So that might be 10, 15, 20 years. And so we need to think about how are we making social care attractive in the broader labour market, but also how are we investing and valuing the experience that people have as they develop through the system. And the question about funding is another question. But when you look at turnover, for example, there are costs in the system if we don't do this. So when we look at home care, and Jane will know this, we've got higher turnover rates in home care than other types of social care. When we look at what are the factors that impact on turnover, we did some analysis of our data, and what we looked at was so if somebody is paid more than the national living wage, if they have training, if they have a social care qualification, if they're not on a 0 hours contract, and if they work more hours, your turnover rate is about 20%, still high, 20%. If none of those things exist, turnover is close to 50%. And so there are things that we can do. It's not just pay, but that's the focus that we need, and it's some of the conversations that we're having as part of the workforce strategy.
Okay, thank you. So, Nish, I was reading the staff survey yesterday, which is 707,000 respondents. It's a pretty good data set, really, and only 50% of the respondents said they felt able to improve or change practice in their own place of work. So from your experience working with earlier career GPs, do you think those numbers would be similar if you're a GP, a registrar, or early career GP? Do you think there's more capacity to be involved in transformation and improvement?
I think it probably varies a lot depending on where you work, and it comes down to good leadership in the end. If you work in a place where you have a leader who recognises that somebody at the start of their career can really contribute to changing and improving things, and has a culture where you feel able to do that, and it can make such a big difference. I think particularly sort of younger people can help around technology, AI, recruitment. They've got a lot to offer if given the opportunity to do that. I think there's a really good story. So I was in Australia for a year and came back very reluctantly, and started a job in paediatrics at St Mary's, working with Bob and others, and was given lots of space and permission and psychological safety, going back to what we talked about yesterday, to try and change and improve things. And I went from being a disillusioned young doctor who'd come back from abroad to finding myself staying after hours to work on a project to improve patient care. And that came down to having good leadership and mentorship and that permission to do things. So I think if you give young people the space and the time and the safety, they can make a tremendous difference.
Thank you. And briefly, because I'm being told we have to go out to the floor, but I just wanted a comment from Crystal about the proposals around apprenticeship training and nursing associates and the expansion of those roles, what impact that might have.
David, I don't know if you saw that we released a position statement from the Q&I just 2 weeks ago around nursing associates, around the exploitation of nursing associates. And so nothing against nursing associates. We absolutely need them in the workforce. We need them to be trained and supported, but their scope of practice is all over the place, and particularly in general practice. And what we have found is that the scope of practice is not set by the Nursing and Midwifery Council, though they are regulated, a registered professional, but the scope of practice is set by the employer. And there's a lot of misunderstanding around nursing associates and what their scope of practice is. And we have had nothing but support after we released that statement from nursing associates, from GPs, RCGP in fact, from nurses working in general practice, from practice managers. And I hope that we're going to be doing a piece of work with RCGP around the scope so that we can do some guidelines around that for GPs.
Okay, thank you. So if we go out to the floor, if we maybe take, say, 3 questions at once, and gentleman at the back there, and then lady over there had her hand up, and then gentleman there with a pink shirt. I can't get to everyone, but we'll try. Okay.
Thank you. My name is Masood Fouladi. I'm a co-founder of Circle Health. So I've been struggling with this issue that you're discussing in the private sector. So it's not about public sector. It's a private sector, charities all have the same, and it's international. My own experience is, apart from money, if you don't pay them well, forget about the rest. The second part is development, and the third one, which is leadership. We always looked at the leadership of organizations should reflect their staff. We have 50% of doctors from ethnic minority, only 20% of medical directors are from ethnic minorities. Now, we come from 5% last decade, so we make progress. But what Billy put, and I completely miss in my business for the last 20 years, the generation millennial and Z, they are 51%, but they are not around the table. So I never reflected them in the leadership. And Clinton in the last panel said, if you're not around the table, you're on the menu. So how we can do that?
Thank you. Oh, microphone over there. Well, you go first, and then we'll come. Yeah.
Tim Loynig, academic, think tanker, consultant, former government official. What I want to plea for comparative evidence. What is the equivalent for teachers compared with nurses? Is this a cross-government effect within Britain that's caused either by social change, for example, a preference for part-time working and flexibility, or by austerity? Within 5 years, 31% of teachers quit. And secondly, for international evidence, nursing is not for everyone. And if you start age 18 on a nursing course, as a friend of mine's daughter has just done, you might find that however committed you were till you started, you absolutely hate it and it isn't the career for you. So again, what's the international baseline? What does good look like? Because I don't think it's 0 people ever quit, because not everyone is cut out for any of these careers.
Okay.
Thank you. Nana Suji, Chief Exec at Northmid and also new trustee at Nuffield. I'm going to continue along that line. I read a book called The 100-Year Life, which made me stop and think. And I suppose I was listening to what you were describing, Billy, in terms of almost a linear and stochastic approach to careers. You train, you work, you retire. And the book suggested that that's no longer the paradigm. We talk about people leaving as though it's a one-directional thing and something to be feared, but actually, is that not now going to be the norm? And what is our approach, therefore? Is it different in health and care to a life where we reinvent rather than remain on a unilateral career trajectory?
Thanks. So I'm going to come to Billy first and take any of those comments or questions that you want to.
Yeah, I'll start with the first one. Masood, your comment about getting these younger generations around the table in leadership, and it plays to your point around people wanting to lead that entrepreneurial feeling. We know that I think it might be US data, but they asked Gen Z, and they asked the other generations, do you want to own your own business at some point in the near future? And Gen Z are twice as likely to want to. So we know they are more entrepreneurial. We know they want to have ownership. So it's a really obvious move then of, well, let's give them that ability to, that sort of autonomy and that responsibility they need. And that, it sounds like you had an example where that worked and that sort of kept you in the system. So we know that it does. You asked me just to do one. I'll just quickly on what other sectors. I'm not pretending for a second this is exclusive to health or social care. And I don't think it matters if other sectors are struggling and trying to challenge with the same things. We can learn from them. But I'm not sure in sort of, if you look across public sectors, there's a gold standard to look to at the moment. I think we're all fumbling with it. And let's, for a change, try to get ahead of the game, which usually the NHS and social care aren't typically.
Okay. So for the other panellists, you don't have to answer all three questions, but Crystal, is there anything you want to respond to?
Yes, thank you. The point about zero attrition, I don't think that would ever be possible, and nor should it be. But I do think that we have to be realistic about how we present nursing. And we've done quite a lot of work at the QNI on the way in which changing the narrative around nursing being presented as hearts, flowers and teddy bears, which it just simply isn't. And it is hard work. It requires an undergraduate qualification and a professional registration, and it requires continuing professional development constantly throughout your career. But if we are presented as hearts, flowers and teddy bears, we're going to recruit the wrong people.
Okay, Nish?
I think I'll just talk about the 100-Year Life. I think I recommended that book to about 5 people yesterday at dinner, so it's very interesting. I don't read many books twice, my millennial attention span being what it is, but that is one that I did read twice, and I really recommend it on this topic. So I think what it says, which is really interesting, is that we are going to be working for much longer. So that typical model where you have education, a long period of work in the same job, and then retirement, what they call the 3-stage career, is not going to exist anymore. It's going to be made of multiple stages where you're moving around, typically with, at the start of your career, maybe so they talk about it as juvenescence, when you're 18 to 36, lots more exploration of various things, and then later on in your career, reinventing yourself and taking sideways steps. And this is something that we don't actively support or encourage at all, I don't think, in the NHS. We really need to play the long game. So here's an example. My husband was a neurologist, and he was asked to come and do some research for a biotech. And he was basically presented with the option of, if you want to take this new opportunity, that's it, that's the end of your NHS work. He asked for a sabbatical, a year out, part-time working, can I just go and explore this for a year and come back? Was told no at every turn, and then decided a year ago, right, I'm going to leave, and he's left. And I think that's just so short-sighted. He could have been kept, one foot could have been kept in that door and he could have come back. Someone should have recognised, you're at the start of your career, go and explore things. We might then be able to keep you. But we have a very sort of short-term view of, computer says no, you can't be flexible in our thinking, we've lost the doctor. But I definitely recommend that book. Thank you for mentioning it.
And I think I would say social care needs to be the beneficiary of this desired work-life balance, change, flexibility. We can do that. We don't, you can come and work in social care, you don't need 8 years training to get there. You can come in to work in social care without any training or qualifications, and we will train you when you get there. And you can do it as a second job, and you can start in social care and move into a whole range of different roles because of the skills and qualities that you develop there. I don't want us to be afraid of that. I don't want us to be afraid of losing people to the NHS or the health service. I want us to embrace it as long as we're getting enough people in, because actually what we what people get in terms of the really relational skills that you have in social care, the negotiation skills, is invaluable absolutely anywhere. So I want us to be ready to take advantage of that, I think. And then the comparing to other sectors, I think we've got some sense of that. So social care used to have about twice the national vacancy rate, and over the last few years that's gone to 3 times the national vacancy rate. We can look at the impact or the difference between NHS and social care. So we do have some of that, but what we don't have is a sense, I think, or a common shared sense of, well, that vacancy rate would be okay, that level of churn is okay, and I think we need to get a bit better at that. And then just thinking about broader diversity and representation around the table. In social care, we've got an incredibly diverse workforce, and that's absolutely wonderful. I would love us to be known as the most diverse and inclusive workforce. So about a quarter of our workforce is from diverse ethnic backgrounds, but that does not translate into leadership roles. So it's only about 16% in leadership roles. And yesterday, Skills for Care published the social care workforce race equality standard report, and some of the data in it was quite stark. So people from diverse ethnic backgrounds, half as likely to be on a shortlist, 20% more likely to experience bullying and harassment. And so that desire to be the most inclusive workforce is, if we want to get there, we've got to have different conversations, I think. But there's a real, I want us to be ready to take that opportunity.
Okay. Thank you. Dr. Rosen has made an early bid at the front there. And then I'm looking for 2 more. So there's 2 people at the same table there, Anne-Marie, and then a gentleman with a blue shirt at the back. So
Thank you.
Someone can take the mics to that table.
So Rebecca Rosen, GP in South East London and fellow at the Nuffield Trust. And the thing that I wanted to just slightly shift the attention to is late career shifting attitudes, where having worked long and hard for many, many years, people may retain a commitment and a loyalty to the service, but just want less intensive work, or struggle to deal with some of the changes that they're being asked to accommodate after many, many years of change. And we've talked a lot about retaining people at the end of career, and we've envisaged an enormous number of potential roles, so mentoring, supervision, changing your clinical portfolio, but we are doing extraordinarily little about it, and it seems like something that should be a tractable issue. And I think some of the barriers are an insistence in most places, if not all, for example, that you complete your full course of mandatory training. And I have tweeted in the past about the utter absurdity of annual fire training. And if I'm the equivalent, I have to say, in general practice, of 6 full-time doctors a year of mandatory fire training time. Well, to match the loans forgiveness, could we perhaps have regulatory forgiveness, where you are able to carry on doing mentoring and supervision, but perhaps not have to do the full gamut of mandatory training? And I think there are variations across deaneries. So some deaneries are willing to have hospital consultants for 1 year after they've retired to carry on supervising fellows and new clinicians. Others, it's 2 years. Can we give some thought to that, about how long it is legitimate to have to be able to do these things without having to completely revalidate and do all your mandatory training? So I think there's some thinking we could give about keeping people's expertise, wisdom and knowledge and enthusiasm late in careers, which could really benefit the younger people. We've got the furore over physician's assistants. In general practice, we do not typically have time to supervise them adequately. Please let us retain some of our close to retirement GPs to do that kind of thing.
Thanks. And at the back there.
Thanks very much. Anne-Marie Rafferty, Nurse Academic, King's College London. I just wanted to address the possibility of using these generational changes or shifts to create a kind of intergenerational approach to trying to solve and at least come up with some further interventions or strategies to deal with this problem. We know that, that can help intergenerational mentoring, grannies like myself and very young ones, is actually being actively deployed at the moment, but it's not been evaluated in any shape or form. So I think that might present an opportunity. I think the second point is about transferable skills. A number of panel members have raised those. I always used to say to students as dean, you know, whatever you do, you know, we don't want to lock people in or feel that they get trapped. Whether you decide to stay in this wonderful profession, you're going to get the most extraordinary range of transferable skills and, you know, kit back that's going to like stand you in such good stead regardless of where you end up in your career. We hope you stay, but if you don't, there's the deal. And it's rewriting the narrative that Crystal, you know, spoke about in a different kind of marketised form. Then I think we don't pay that much attention to what we gain in terms of assets from career switchers. You know, again, thinking of healthcare as renaissance careers. We're interested in people with a whole variety of different talents. Our students who come in with graduate backgrounds in particular, sometimes it's a second, sometimes it's a third career. Boy, they're in huge demand by employers. They've got stacks of life experience and they fear nothing. They are brilliant. So let's be targeting those students and help them with some loan forgiveness, because otherwise they've got two lots of debt and that's just too much. Thanks.
Thank you.
Thanks. Here to that, Paul Farmer, Chief Exec at AGK. Three very quick points, going all the way back to yesterday morning, was it? Thea's point about psychological safety. I think this is such an important issue for thinking about how we hold people, and yes, it's in the NHS, but I think psychological safety in the social care workforce is also something that's hugely important. Secondly, this morning on the Today programme, there's a long discussion about worklessness, and the two groups who are currently not working are the 18 to 25s and the over 50s. So it feels to me that the point about intergenerational engagement is really important, about how do we bring how do we tell that story and make our story more attractive to groups of people who are not currently working. And thirdly, just to expand it's really great to hear the reference to the voluntary sector workforce as being a part of all of this. I think our experience is often that we are both the starting point and the finishing point for people in their career journeys. And of course, for some people, we're their entire point. And a lot of the skills that people bring into the voluntary sector are hugely transferable. We also hear that the funnel feels very narrow for some of that transition to take place. And just finally, a point about volunteering in all of this. Huge numbers of people who are volunteering in and around the NHS, in and around the social care system. I'm not quite sure we create that connection into a huge bunch of people who would actually quite like to do it for some money, as well as doing it because they love it. Thanks.
Thanks. Well, I've got about 7 minutes left. We have to finish on time. So I think I don't think we can take another round of questions at the moment, because by the time the panel have responded to those points and then had Jerry Springer-style final thoughts, we're probably done. But I mean, are you all around to be approached afterwards and, you know, not rushing off? So you first of all, Anna.
So I think one of the themes that came up in a number of those questions was around the potential that we have if people are close to and understand, I'm going to talk from a social care perspective, but understand social care, the potential untapped workforce there. So we do actually get quite a lot of people in their second careers in social care, and that's often because they've had experience or they've come into contact with social care before. We need to make the most of that. So when we were looking at skills for care, particularly around men, what we found was that the men who do come to work in social care are often over the age of 55, who've had some experience of caring in their past. It might be caring for children, it might be caring for family members, and they're much more likely to both understand and value social care, and they're much more likely to come into work in social care then. And also the use of other of our own workforce now. So I will be friends with people with similar values to me. And if I have exactly the right values that we need in social care, then we should be tapping into my friends because they'll have a similar value set. And so how can we use our own teams as recruiters and what our teams are talking about with their friends? If they're loving their job, then their friends will go, there's something quite interesting there. So I think there is an opportunity there to increase the contact that people have with social care and to make the most of that. And it also goes to Paul's point about volunteering. If somebody is volunteering in social care, you don't have to get over the initial hurdle of, oh God, I don't know what social care is, because you do. You're there, you're in that world. What we want then is to build on that understanding. And then I wanted to pick up the point, which I know wasn't aimed at social care, but in terms of the kind of decluttering of some of the some of the learning market. So the Department for Health and Social Care and Skills for Care has worked recently on a care workforce pathway, which is our setting out of that career pathway for direct care workers initially, and we will then move on to deputy managers, registered managers, but so the purpose was to support with career pathways, but the next stage is then to look at, well, how do we declutter the training market or the learning market so that what we actually have is people doing the right development instead of this inefficiency in the system where we're constantly repeating the same training again and again. And I'm registering in 3 home care agencies in London, and I'm doing 3 sets of training again and again. So how do we both declutter but also build in trust in the system? And I think the care workforce pathway is a real opportunity for us to do that.
Great. Thank you. Now, I'm mindful I've got about 4 minutes now, so we're going to have to, as we go... No, you don't need to be skipped. If you've got anything you'd like to...
Just to really agree with your point, Rebecca, about using older GPs in a different way. I think we have a tendency to look at GPs in terms of their utility of how many patients they can see, and if it's about anything else, it's not that useful. But I was thinking back to a conversation I had with Sir David Haslam yesterday about how... general practice is like a crying baby, he said, and you love the baby a lot, but actually you don't want to be around it all the time. And I was thinking that as a mum of young children, I think I'm probably a better mum when I take some time out, like I have for this conference, to spend time away from my children. I'm sure I'll be a better mum when I go back to them tonight, maybe. And also with parents, you're sort of locked in and you have to stay in it, but GPs don't, so they'll otherwise vote with their feet if they don't get time away from the crying baby sometimes.
Thanks, Nish. Crystal?
Thank you, Rebecca. I think that links very much to Anne-Marie's question as well. We've got nurses who are hitting 55 and can retire. I know that won't last forever. That's a particular age group that's got the old NHS pension. They can. They don't actually want to give up full-time work, but it's hard physical work to do this 12 hours a day, sometimes in the home on your knees, doing wound care, end-of-life care, all sorts. It's hard work. So yes to that, but we don't make it easy to retire and return, and we're not intentional about giving a role that is around mentoring our next generation or the current generation, linking that to retention. What if we did something really positive about deploying those who want to come back into our universities, not necessarily to teach, but to support and mentor those who are thinking about leaving, but giving them options, maybe pointing them out of the nursing career, but actually supporting them to have a good ending or to stay. And a lot of the nurses leave because they say they're not supported, they don't have the mentorship, they don't have the preceptorship when they first qualify. So using those, and there is just something about, as I get older, the joy of being around younger people. It's wonderful. And to see the hope that they have and the dedication for our health and social care system. So I really get a lot out of that. And I hope that when I get to the retire, I can do some return as well.
Thanks. And finally, Billy?
Yeah, just in response to those 3 points, thanks, exactly. You focus on generations and you show there's a solution, of which there are many. Go see our colleagues at the back, excellent comms team who will help you write a blog on exactly that. I mean, let's get these solutions out there.
Thanks. And just final thing I'll say is it's impossible to represent every part of the workforce on this panel. I'm very mindful we don't have an allied health professional or a pharmacist up here. I'm very mindful that the non-clinical workforce also matter, but I think all the considerations we've discussed about generational differences and attrition and so forth would apply across the workforce. And maybe next year we need to get an AHP up here. But anyway, I'd like to thank all of the panelists. And I think we're over to the Chief Executive now for the final session.
Thank you. I'm just going to hold you here for about another 10 or 12 minutes, maybe less. So just bear with me. Because it is worthy of just taking a pause and reflecting on the day and a half we've had together and the evening we've had together. And I'll share my reflections, and I hope you'll continue to share yours. It is International Women's Day, and I want to start by saying I'm really grateful that I have a lectern I can see over. As a short woman, I am frequently faced with lecterns that come up to here because I wear flat shoes, and other short women in the audience are nodding at me. But it is, whilst an amusing point, a structural point. Society is made often for tall men, and the way we have surgical tools, the way we have a whole range of instruments in life, are often not made for somebody of my size. So my comms team actually made sure that I could wear flat shoes and be seen over this lectern. So I'm very grateful for that on International Women's Day. There's so much that I will reflect on as I go away from here. There are two statements from today that I'm afraid I will laugh about on the train as I go home. The crying baby, just recently, that we love, but we do need a little bit of time away from. Colleagues earlier who talked about at the end of the world there'll be cockroaches and two people arguing about integrated care, I will continue to laugh about. And I've enjoyed a huge number of sort of magic moments and reflective moments during the day and a half. I started the conference talking about the need for us to bring data that is quantitative and scientific together with encounter and experience. Clinton made it much simpler. He said we need to talk about data with soul. And I think that was lovely, and I agree. We heard from Naina, who talked about the 100-Year Life, the book, and was reflected by others on the panel as an excellent book. I'm wondering whether or not at our next summit we should make sure we have a book list that comes out. Because there's so many books people mention at various points, I actually think we should capture them. We should have a summit book list, because I keep putting them down, but I don't think I've got them all. What the summit aims to do is enable all of us to get under the skin of an issue and hopefully to give us the ability to challenge and think a bit differently about issues that we all think about all the time, but to help us give a space where we think differently. For me, I found the risk session really gave me an amazing reframe. And I've been lucky enough to talk to people on that panel as they prepared for the panel. And I've reframed and reframed as I've listened to them talk. And I know, talking to other people, because I've asked people, what are your magic moments from today, as I've been running around during the breaks? Many of them have reflected on that risk session and that reframe, and where that takes us, because that's just the start. A lot of people have reflected on the AI session. That was an amazing session where we all ran to keep up with Jess as she told us a huge amount of information, and we can all look at the slides later. But I know I go away, I think, with more of an ability to be in a room where people are talking about AI and ask a range of questions in a more intelligent way. And I find that really useful, and I know I've heard other people say that as well. I know that in that conversation, we also heard our colleague from the Stroke Association talk about mechanical thrombectomy. I've tried to write it down properly, and I probably have got it wrong. And the impact on disability. And because we underestimated the workforce shift and cultural shift that you need to do any redesign, it's still not with us. It was a really striking example and really sat well in that AI session. and really sits well when we think about the budget, about saying, if you don't think about the whole workforce and transformation that's needed with any kit, you're going to get nowhere. Chris Whitty talked to us elegantly and interestingly as ever on quality of life and quantity of life. It's something we all probably talk about. We talk about in our families, but actually asking for a national debate, I think was a very brave thing to ask for. I don't know where it will be picked up, but I absolutely think we should amplify that voice and conversation. And he talked about us looking at the hard realities of what we're facing. We all know what we're facing, but it's very similar to climate change. We all know what we're facing, let's go and do something else. But it's going to be dreadful. I hope somebody does something about that. It actually is us, and we really do have to do something about it. And he talked about the fact we'll never be able to buy our way out of this problem. We're either going to have to make people healthier, think of different ways of using tech, or have a completely different approach to workforce. And that 440,000 gap in the social care workforce has been mentioned several times. It was mentioned by Chris, and it was mentioned again by Oonagh today. And really understanding that and really focusing on that is something we have to, put our collective hive mind around, because it's not going to go away. We have the way we're seeing the impacts of climate change. We are going to see the impact of this. It is inevitable. I learned a phrase this morning, hostile care, which I've never used, despite having been in the field of community and primary care for most of my career. The idea of hostile care, i.e. you've got to come and help the hospital, not really thinking about where are we in that space, I found very interesting. Specialists and generalists is a theme that's come up again and again. And I hear those of you who are leading in the field really working on how do we get this generalist training back into all professions. We've talked a lot about doctoring, but it's absolutely with nursing as well. My world was community nursing and primary care nursing. I'm sure Crystal would agree. A GPN can't do what a community nurse can do, and a community nurse can't do what a GPN can do. I mean, there are huge specializations that we are going to really have to tackle. If we have the real opportunities that are there in the long-term workforce plan to have lots of training, lots of new roles, we have to seize the opportunity to really understand the focus on generalism versus specialism. I'm not sure we will, but I think we have to. And we have to understand parity of esteem. There absolutely isn't parity of esteem between working in different sectors, and we have to grasp that if we're going to solve any of the problems we've been talking about today. I learnt which generation our prime ministers have come from, and I found that very helpful for any pub quizzes of the future. And there have just been many, many facts that I have loved from this time. So there are two more things that I want to talk about. And I've lost my pieces of paper, which is very unhelpful. Oh, I've lost one on the floor. Right. So I need to talk about an individual now, and I need to talk about Helen Buckingham. And this is Helen's last summit. We think she may be invited in the future, but it's her last summit in which she is a core, valued, extraordinary member of the Nuffield Trust. And Helen is going on to a whole range of great, good, and amazing things. And as we tend to invite great, good, and amazing people, she may well be here again. But she's not here as a member of the core team. And I've only been at the Nuffield Trust for 5 months, but in that time I have seen already the impact she has and the work that she does. She has done a huge amount to make the organisation the professional, well-run, well-respected organisation that is today, and she will be very missed. So this is one of a start of places where we will embarrass her in public places, and so she can start with that today. And in fact, we had a room named after her here. I mean, that's how much we value her. So it's really important to notice that. So I want to say thank you to Helen. And finally, on your table, you have a form. It's an old-fashioned analogue form because it's been proven statistically that more of you will fill it in, actually, than if we let you leave the room and you pretend you're going to do it online because we know you're not. It's in the delegate pack. If you can't see it in the delegate pack, colleagues will run to your table and thrust it into your hand. Put your hand up if you haven't got one. Don't be embarrassed. Somebody will come to you. And put your hands up. So, comms colleagues, can you find them and give them to people, please? And you're not allowed to have lunch until you've filled it in. I know it's sad, but, you know, that's the way it goes. So, thank you very much. Thank you for coming. Thank you for taking part in the conversations and continuing them. Continue the conversations afterwards, and please drop me an email if you think that was good, but it could be even better if, because I'd like to hear from you. Thank you very much. Lunch will be served next door when you filled in your form. Thank you very much. Bye.